now? Okay. Okay. Right. I split my presentation in 3 different parts, and we see, and thanks to Christian, and that is magnification, precision, longevity. It's a very important for me, was the topic when I started to work many years ago. And the approach today depends of direct and indirect. It's the same like many years ago. And we have different reason to decide to do direct online veneer or crown. And depend of tissue or depend of vitality. Many authors give us some knowledge to have maybe the opportunity to use composite or ceramics. Of course, is it more conservative, etc., repairable, etc. Long-term clinical expertise, etc. But to me, the most important thing are 4 different reasons. But frankly, if you see 3 different articles, the idea is vital or no vital, endo or no endo, and the residual coronal tooth. That are, to me, very important. And my approach when I do some restoration like direct like that, depend of ability, age, level of modification, phenotype, request, and longevity. There are many reasons, like our job, this decision, depend, of course, rules and protocols and processes, but subjective is a very important approach. But frankly, this article some years ago, 2011, I completely disagree because porcelain is not pornography. Pornography is another story. I think porcelain is an option to solve the problem about the patient. Where there are no integralists, it's not good to have integralists in our job. My approach is to have perfect integration, like every kind of doctor and dentist. They solve the problem difficult, like one single crown, like that, or have a different approach, like I will see you after, I will show you after. Of course, we try to do excellent. Excellence is not so easy to do and depend, of course, to many, many important things. The topic about join us, me and Jose and me, is a microscope. The microscope is a new experience. It's a wonderful approach. Of course, precision, longevity, magnification. Like Christian told us, I expert about that because I started many years ago. I believe it in that many years ago. And now I want to maintain the same approach in the focus about that. It's another system. The protocols changed completely my life. And during my time, I changed the approach of without drawers, storage trays, and etc. Because the point of view about this instrument is another story. Many people thought it's not so important to use. For me, it's fundamental. And you can see my group to work together every day. I want to thank to my group because it's very important too. You can see Marco Jakovac. I hope Marco is attended all the webinar today. This is Carlo. And the Carlo Ghezzi, it's a great periodontist. In my office, and this is myself before the terrible period, before COVID period. And then Alessandro Conti. Okay, in this approach, we're still in the same concept to do that. I want to thank of my group. It's an impressive group to help us during the day. Of course, the reason to use the microscope, absolutely accuracy, it's the most important thing about that. But for me, it's not so true because like in literature, it's not so many articles about the literature, about the microscope because it's not so popular. Now it becomes a little bit better. And you can see different approach to use in different approach, but really uh, about this instrument, less working time, absolutely. Because it's an incredible instrument to go fast when you understood very well the approach about that. But, but the reason to use the microscope is that because in our job, we have a lot of disease, depend of disorder, trauma disorder, you can see, and different musculoskeletal disorder. And now the articles about that, there are many. And it's incredible, 65%, 75% of dentists suffered of this disease. And of course, the pain also is about the musculoskeletal pain. And that is true because when I asked the student, I told I have a problem about ergonomically approach the equipment depend and you need to. If you want to see without any, of course, our body is not in good way. If you use the loop, you have a little bit better, not perfect, but quite better. And with the microscope, completely change that. We can use different magnification and you can see panoramic point of view. And then the reason of to use the microscope with the posture, that is the most important thing. Is so not so good? No, it's a wonderful, absolutely the reason to that. In our, my approach, I have two important results. One is the MSc, Massironi Study Club, a group of my ex-students. It's incredible group, talented, many talented too, and 65% of participants or the members use the microscope. That is an incredible result too. And of course, we invest. I invested in the Mag Center, and that is a reason to use the microscope. I want to give the podium to Jose now. It's okay?
Sim. Oi, Zé. O palco é seu. Pode entrar.
Hello. I'm trying. Okay. Hello, everybody. Chris, can you see me? Is it okay? Okay. I'm trying to share my screen here. Okay, there you go. All right. Okay. Hello, everybody. It's a great pleasure. It's an honor for me to be here. Thank you, Chris, for the invitation. Thank you, Nini, for the opportunity of sharing the stage, the virtual, this stage here with you. It's a great honor for me. And you know how much I look up to you. You are one of my mentors. And this is a great opportunity to show a little bit of what I have learned also from you. Okay, we're going to talk here a little bit about magnification, about direct restorations, indirect restorations. Okay, the part that was up to me here was to talk a little bit about how we do direct restoration. Oops, I think it closed here a little bit. I'm sorry about that. I think it's too heavy. Sorry about that, people. Okay, we're going to start talking a little bit about magnification, which is an important part of everything we believe and everything we're going to do in our everyday practice. Okay, everything we do in our practice, we do with the use of a microscope. So magnification is an important part of what we use in our everyday practice, in our everyday dentistry. Okay, so magnification, if we could give a meaning for that word, would be the possibility of better visualization through an instrument to obtain greater operational precision. Which means you need something to see better so that you can do better in your practice. It's some kind of a quality control. It's something that you can use to make a quality control in your practice. But at the moment that you are doing your operative procedure, okay? So I would say that quality control in real time would mean how much correct diagnosis and precision is necessary at the time of the procedure that you make, okay? And this kind of precision can only be achieved with the help of an instrument. Okay, so there are several magnification instruments available to us. And of course, the most simple one is the human eye. Okay, the human eye is a flexible optical system that can adapt to various requirements. So we know that the eye is just like a camera, where the retina would be the sensor, okay, the crystalline would be the lenses, and the iris would be the diaphragm, which controls the amount of light that comes into the eye. So we know that if we have a small object at a far distance, that object is going to impress in our retina. If we have this small object in a far away, okay, it's going to have in our retina a very small viewing angle. That means that we're going to have just a few amount of cells being impressed by those lights. Okay, so we have just a little bit of information, so you don't have much detail. But if you bring the object closer to the eye, closer to your face, you're going to have a larger viewing angle, which means that more cells will be stimulated by those lights, and you're going to see more details. So the easiest type of magnification, of course, is to bring an object close to the eye. And dentists know that, because dentists do that every day. They bend over their patients trying to get the closest they can, okay, so that they can see more details. But the problem is, if you get closer than 30 centimeters, you don't get focus anymore, all right? If you could get more focus, getting closer than 30 centimeters, you would see even better the amount of details. But the thing is, it's impossible to do that. And you would be very close to the patient. And the thing is, when you work like that, you're going to have a bad posture. And imagine working like that for the rest of your professional life. That's not healthy. And we know that. So there are other instruments. Okay, maybe one of the first ones that we use, not just to record what we were doing, but also to make sure that what we were doing had a good quality, would be the camera, the 35mm cameras. This is a Yashica dental eye that I used to take pictures of the things I used to do, just to make sure that I was doing properly. But those pictures are a magnified vision. Okay, these are pictures that I took. Those are paper pictures that I took in 1991. So 28 to almost 29 years ago, okay? And those restorations, okay, after a while, they are still in the patient's mouth after 28 years, okay, almost 29 years. Okay, so the onlay is 28 years old, and this composite here on the premolar is 27 years old. So it helps a little bit with the magnification. And with the digital camera, it's much easier, all right? Because you can check, you can enhance the visual, you can enlarge the picture, and you can see detail. The problem of using a camera in everyday basis is that you don't have quality control in real time. This is a video that I got from a friend at the University of Montreal in Canada, showing that when you have to take a picture, you have to take everything off, you have to stop what you're doing, you have to get the camera, you have to take the picture. So it takes a long time. Okay, so it's pretty messy to do that. Okay, but then we have the loops. This is not a loop, okay? This is a piece of plastic that doesn't do you any good, all right? It distorts and you think it enhances a little bit, but it doesn't. This is not a good magnification instrument. This is a good one. This is a node loop. This was the first one I had from Designs for Visions. So these loops, we have many brands on the market in Europe, in the United States, in Brazil. We have some good ones. Some of them are what we call TTLs, which are through the lenses. They are fixed binoculars like this one here, okay? So they're custom made to your interpupillary distance, to your working distance. And then we have the flip-ups like this one here, which are fully adjustable. You have to adjust everything. I prefer the ones that are custom made. They're lighter and they're more stable. They have better vision, but they're both good options. We have the Zeiss loops, which I think is the best one. But bottom line, loops gives you better dentistry, better ergonomics. It has fixed magnifications, okay? So you have usually from 2 to up to 6 times magnification, but they are fixed magnifications. If you want to have 2 and 4, you have to have 2 loops, okay? There's an adaptation time required. There's always an image distortion, especially around the area, in the periphery of your vision, and the distortion is going to be worse. The worse is the quality of your loops. So that's why loops are not all the same. The very cheap loops, they have a lot of distortion. They have a lot of color alterations. They have a small depth of focus, the bad quality. The good quality ones, you have less problems, okay? It's a reduced working field, okay? The more you enlarge the image, the less amount of area you can see. You see more details, but the area is smaller. Okay, it's heavy in high magnifications, and because of that, can cause fatigue over long periods of use. But if you're going to use a loop, you always choose the greatest possible working distance because that gives you best visual field and also a better posture. You have to remember that magnification, any magnification device, reduces the amount of available light. Okay, therefore the visibility. So, and there is a math to that, okay? This decrease of light is proportional to the square of the magnification. That means if you have a 2 times magnification loops, you have 4 times less light at your visual field, okay? So it's interesting if you associate a light source, like a headlight, but the headlight should be placed like this one here, at this position here, not like this one that usually people do, okay? Why? Because if you have the light between the binoculars, you don't have much shadow on the object as if you put the light on the top of your head, all right? Okay, and then we have the microscope, the operative microscope, okay? Someone might ask, is that one more panacea? Do we really need that? I mean, I think it's essential, as Nini said, you know, it's essential. You know, we don't have much information about that in dentistry, but the first paper that we have is from 1977 from Baumann. And in 1981, Harvey Apotheker, this guy here, you know, sorry about that. Okay, Harvey Apotheker, he built the first operating microscope designed for dentistry, okay, which was this one here. It was just one step magnification, was 8 times magnification. It was produced by Chase Virginia Corporation, and later on it was bought by Johnson & Johnson. Didn't do much success at the time, but was the first attempt to bring, you know, really the microscopy into dentistry. And then we had Gary Carr bringing the microscopy to among others, okay, there are several dentists around the world, some in Europe, some in the United States, many of them at the same time. But Gary Carr was one of the first ones to use the operative microscope in endo. And then we have Dennis Schenelak and Leonard Tibbetts bringing the magnification with the microscope at periodontal surgery. And I have had the pleasure of meeting Dr. Mark Friedman from the University of Southern California. He was the guy who introduced me the microscope in 1997. And then after that, I had the pleasure of meeting another friend of mine, Glecio Campos, which is a great periodontist. He helped me in the beginning using the microscope. And then I had the AMAD. The AMAD is the Academy of Microscopy and Dentistry in the United States. And that's where I met this guy here. That's where I first met Nini. I already knew him. I knew him from his book. His book, Precision in Dental Aesthetics, was like a Bible to me. It is up to now. And he's a good friend. He's a man that I really look up to. And he's a genius. He's an artist. And I'm not just saying that because he's here, because this is a slide that I always have in my presentations, because I always pay this tribute to him, because it's very important to me. So thank you, Nini. I want to have this opportunity to do that. So the microscope, it has all those parts and everything. We're not going to go through this here. This is not our point. But the interesting thing is a 5-step microscope, let's say one that is 3.5 magnification, 5, 8.5, 13, and then 21. We see that the more we magnify, the larger the image gets, the smaller is the operative field. Okay, so if you have 3.5 times magnification, you can see like 5 teeth in a microscope. So let's get this one. It's smaller, okay, which is smaller. You don't have the same field. You also have a distortion on the side, and you also have less light. So if you compare a 5 times with a loop and a 5 times with a microscope, it's not the same. It's not the same thing, okay? I'm not saying that loop is bad. Loop is great, but microscope is better, all right? And microscope 5 times is a small magnification. This is large magnification in microscope, okay? You can see that. And you can also see there is a caries over there, very small caries over there. So it's very important. We see that we can work at small magnification microscope, medium magnification, high magnifications. We can exchange depending on what we're doing in what we are working with, all right? And we know that the benefits of the microscope is not just magnification. It has the best illumination. It's the shadowless coaxial light. So you don't have a shadow. It's as if the light is coming right through your eyes, okay? You also have parallel vision. It's the same feeling as if you were looking at the horizon. So all the muscles in your eyes are relaxed, which is different from the convergent vision that you have with the naked eye or with the loops. Okay, so another important thing about the use of microscope is the documentation and communication. You can attach to the microscope either a digital camera or a camcorder, okay, and you can use a lot of accessories, to get better pictures, to get better videos. And it's very easy to do that. And of course, as Nini said, better ergonomics. Okay, loops give you a good ergonomics, but this is awful when we work without anything. The problem with loops is that usually you work like this. You don't do like this here. Okay, this is just do for a picture. Usually you have to bend over the patient many times. Okay, and when you bend over the patient, this is what you see. Okay, if you have a higher loop, this is what you see. But when you have a microscope, you can see a lot better. The image is really, really much better. All right? So this is how we used to work, before the COVID. This is how we are working now with the COVID. We see that with the microscope, you're far from the patient. You're very far from the patient. And I also use this idea from this friend of mine, Milena. She's an endodontist from Curitiba, and we have like a square piece of acrylic that we adapt at the microscope. So it functions as a barrier to prevent those vapors, those sprays to come into the operator face. Okay, so that's how we're working now with the COVID. And of course, better vision of all details. That's the best thing, okay? Oh, that's it. That's the first part of it. So Nini, it's yours now. Sorry if I took too long.
No, it's okay. It's incredible. Really nice. Thanks for the so important knowledge for us. And thanks for the words. You are very, very impressive, dentist. Really, believe to me. Okay. The preparation means about, in my approach, precision, because my first focus was precision, and still in this kind of approach. And I split them by the preparation phase into phase. Phase one, prep, just equigingival. And phase two, the second phase, where I move the gingival. I use just one cord, and I move the finishing line close to the gingival to take the impression without remove the cord. In this way, I have no damage to the tissue. Okay, like explained to very well, this is the review about digital, the first book. It's a very nice option. It's not advertisement. It's just because people now ask to have information about the first book, but it was only in Italian languages, and now it's available in digital. When I started, that was the situation. That was terrible. I saw so many decays around to the bridges, and that was the bad dentistry. And my idea, I have an idea to find a different approach to prepare to have the finishing line. Maybe the shoulder, very popular too. Vertical, very popular in Italy also in the past, and now absolutely. And chamfer or another one. In my idea, and thanks to the dental technician, the problem was around the shoulder. It's very difficult to have the perfect adaptation to the material. And the vertiprep, you have, oh, come on, non ci posso credere, non potevi dirmelo prima. Adesso? Sorry. Ma non si è sentito niente? I don't hear my voice. It's okay?
Sim, Nini,
Yeah.
I hear you. We hear you.
But I share my presentation or not?
Yes.
But now?
Yes.
Oh, I'm sorry. I mentioned Moura and Jose for incredible knowledge about the magnification. When I start to the approach in dentistry, that was the situation. The situation was decay around to the bridges, and for me was a very pity, and I want to try to have opportunity not to have so difficult to dangerous result. And the opportunity to finishing was different, but like the same today. One is horizontal, it's a shoulder, another one is vertical, and another one was the chamfer. My idea around the shoulder was the first approach because it's very popular in the past and now also still. But the problem for the dental technician and the material to close in this situation, because horizontally is not so okay. We have a press, a ceramic, we have differences in the development of the technological approach, but it's not so convenient to have some kind of vertiprep is very popular now. Was popular in the past because was the approach of a school, Porta Mascarella, where in the surgeon during the surgery there was a very nice approach to have a vertical preparation. and the chamfer. For my idea, you have no open, you have over contour, and the modified chamfer or chamfer, we have a good contour. But at the beginning, when I started, my idea was to do the shoulder. But frankly, I disagree in a few times, because when I analyze the approach with this kind of preparations by proofs, the result is not so nice. Instead of the other quite vertical preparation, but it's not vertical. For me, the difference is one is line, the other one is no area. Area and line. And horizontally is horizontal too, but absolutely not my approach. But in the past was my approach. But little by little, change in my approach to the finishing line. And thanks to my dental technician, Alberto Battistelli and Romeo Pescetta, arrived to obtain a good result with different material like metal, ceramic, porcelain fused metal, and it was popular, very popular in the past. In this kind of approach, I developed the modified chamfer. It's a chamfer a little bit too deep, but very nice for all the restoration. That is a universal design, just because it's possible to do for every kind of situation. At the beginning, my area was a little bit too big like that, and post and core. Now it's not possible to use the post and core. It's not convenient. It's not in line with the adhesive system like I have now. But my modified chamfer changed during the time and arrived in a new approach, less quantity. At the beginning was like that, was so big deflection and the big preparation. Actually, I don't want to see so deflection. That was the past. Frankly, is the damage of the gingiva is not predictable in the future. That is the reason because I decided to split the preparation to a little part. Phase one, I put the finishing line equigingival, and just to reline the provisional. Phase two, I put the cord, I wait the movement of the gingiva, and then move my finishing line close to the gingiva without touch the gingiva, no damage, no blood I want to see. That is my proper approach. And that is the evolution about modified chamfer. And sometimes I go into vertical because depend of the situation of the teeth. That is my approach. I love this approach. I didn't change my approach, my philosophy. I try in every kind of situation, and I prove many proofs and the precision, etc. I spend a lot of time and the knowledge about that. And you can see the line develop in vertical. Chamfer is not horizontal preparation, absolutely. That is my idea, and absolutely I'm very strong about that. Universal, no human factor in all situations. Technology system, half of the bar. Very interesting because it's not depend of my skill. I'm not so a phenomenon, absolutely. My skill is very basically, but the concept to have some references during the preparation is very important. And then we have two different cores, coating, coarse, fine, sonic, and the chisel. That is the approach about that. It means system. Of course, in the literature, I can see different article about one or the other one, the black and the white. Depend if you want to tell you it's better because some authors tell that. It's so individual, like I spoken before. But absolutely, for me, no horizontal preparation, absolutely, but modified chamfer or vertical in some times, but depend of the approach in after perio, in situation, particularly, etc. But thanks our approach, our precision, it's possible to have a good precision, a good emergence profile in all the situation for all the material. And that is my idea about the Sonic. Sonic, for me, it's an incredible device I use every day. You have different for prep or for inlay, innerlay, and overlay. And that is another story. Is an approach absolutely right, because no touch the gingiva. And then I can try to have the finishing line like I want to, close my restoration and move close to the gingival without touch. It's very nice in interproximally. In interproximally, you can see the movement is elliptic movement. You see the circle. Interproximally, where I have a papilla, you have no damage. I can change the amplitude because in the sonic instrument, we have 3 different amplitudes. Level 1 means finishing and polishing very well. Level 3, we can cut. We can cut very big, strong cut. Depend, you can use water or without water because doesn't produce hot. And that is a very important, very, very important. And then we can use chisel if you want to finish better and the polishing and finishing better and better. Remember, the people tell, oh, you need a lot of time, but the time depends because we want to do better and better and better. It's not clinically, realistically, because it's too much. This is my approach on the microscope. I have different instruments. It's not time to show, but it's very nice because in the work of the microscope means and needs also the instrument, the protocols, etc. But after our job, we need the dental technician. We need the protocols to arrive to have exactly what I want to do. The emergent profile, the precision, depend of material like a metal, and the procedure is very handmade. Now we want to do very simple approach, etc. But Romeo Pascetta is an incredible dental technician. He can do everything about the material, and the same approach for all the different approach, but the same result for different kind of material. And that was important. Of course, it's important function. I agree absolutely about the function. I want to show you now as a new approach of function. But look at in the zirconia, you can see the level of precision. That is the reason because I very satisfied, and the end of my restoration, I'm very happy because the future about that restoration will be not like I showed before. And I spent a lot of time and prove and cut it myself, and just to have the idea what was so important to obtain that. The preparation is very important, of course, is the fundamental. And look at the contact of the bar means half of the bar, or quite half of the bar. It's the technology now, you can save more quantity of reduction. It's depend. I don't want to devitalize the tooth just for prosthetic reason. Of course, preparation means a lot of. Now we have porcelain overlay or composite overlay or vinyl lay, but thanks to the microscope, thanks to the approach in this way, you have a good result to give to the dental technician exactly the thickness to obtain the result the patient asks to us, not just to see white, but depend of our approach. In this particular picture, you can see pictures, you can see the details about that. And it's very important to see the line and have exactly the finishing line you want. The grooves or maybe the bridges or other thing. And it's important to see what thing. In this, you see the time to phase 2, the finishing line, the chord, half of the bar, the result, and the impression. And the impression needs to clear the starting point. I don't want to have 2 chords, 3 chords. No, come on, no, 2 chords, 3 chords. It's when I saw some dentists in the past when I was young, they told me, no, I want to put 1 or 0 chord. Come on, for me it was a surprise. But in my idea to use only 1 chord, why not? It's incredible. Just to have minimal deflection, minimal result for the impression. That is important. But the dental technician asks to thick over preparation. Just to have the emergence profile is not true. The emergence profile depends on the gingiva, not depend of the part of the intact teeth. This is for my dental technician, incredible skill. And they help me in different approach, in different situations. You need to look for the good dental technician to follow and to give you in different material the same result. But the protocols are so important. I need sometimes to use like a bridge, the big bridge in the patient, very old, or in the lithium disilicate, or in other material. And look at in zirconia, in this long bridge, vital teeth, old man, no implants. I don't want to implants because I have a problem for disease. Okay, why not? It's possible, but you need to have the dental technician in high level of skill. And also you need to understand very well, if you want to obtain good results, you need to give to the dental technician good result too. Of course, now is the time of intraoral scanner. I told to my student, be careful. I started with intraoral scanner many years ago. I love intraoral scanner, but the people think we are on the top of the mountain. Absolutely no. We try to go up on the mountain, and probably we go in good way and very fast. But be careful. The treatment depends on the skin. Look at before and after without any crown, just laminate veneer and 1 Maryland bridge. In this situation, I want to help to have the help of Giuseppe Romeo, another incredible guy. And then you can see different results before and after. Or if I am function, aesthetical, and complex, etc., it's close to my office, I ask to Oscar Rosa. In this way, every kind of dental technician can help me, because we need the help of the dental technician. But now the company want to eliminate the dental technician. Come on, it's not possible. It's so important if you want to have longevity too. I want to show you after the longevity. And then, Oscar, you can do that and that. It's possible to have a good result. Or Marco Ferrario, during this kind of approach, because the patient asked me to solve the problem, but it was a terrible. That is porcelain, pornography porcelain, because in this month, many dentists made a lot of disaster. And then when it arrived to me, the situation was very complex and very important to change many things. It was a very terrible situation. And I asked to my colleague and friend, Enrico Agliardi, to help me during this kind of surgery. We're all on 4. In this situation, Enrico, incredible guy, remove the implants and the missing teeth, and that is the situation. And frankly, after a few hours, we give to the patient a new smile and a new face, completely like a provisional. And then, thanks to the Marco Ferrario, the final restoration. We start with the wax, we start with a different look at the difference about the preparation. It's important. This procedure we can transfer in every kind of restoration. But remember, the approach of precision means to have exactly all the protocols in good way. You can reach this kind of result if you have a wonderful dental technician, but be careful. The majority of mistakes start to the clinics. The dental technician receive our result with the distortion. Distortion is one of the most the biggest problem for us. In this way, look at the bridge, look at in other situation, the approach, lithium disilicate, etc. And the result of the gingiva will be good, and that is important. Precision is so important. Yes, because we have a less shrinkage. In this case, laminate veneer is so nice to solve the aesthetic problem, because I know people ask to us the white, ask to us the good aesthetics before and after. In this is particular cases, but I have no time to explain to you. But if you see, the approach depends on the topic of the project, and the precision is still also in kind of restoration. It's very little restoration, save everything of the teeth, and the approach is to obtain in the protocols in the nice result. That is the time just to cement it. After cementation, just to cement it, you see the gingiva. That means very conservative and very delicate. 15 days after, it's not perfect. Everything is not perfect, but it's quite good. And then it's the laminate veneer also. Of course, smile and nice aesthetic before and after. And natural, if you remove the lips, stick lips, you have the natural teeth. That depends on the dental technician, not of myself. And that is so important. Okay, in this case, is the last case, is just to introduce a very important concept for us, because I spend time and I want to develop in this direction. In the case of constricted patient, I used for many, many years the programmer for COIS, and then we can have opportunity to have the position of the final restoration without any maneuvers, because engram motors was canceled. And that is, for me, it's a very precision approach also. In this approach, we have no maneuvers. Sometimes I use the maneuvers. I know very well the maneuvers. I use the jig, the glove jig, etc. But in this situation, it's better to have jig Lucia, because in the evolution of the Lucia jig, and look at the posture of the mandible after the programmer times. But this is important too. But another important thing is this one, Ithaca. Ithaca is a project from Italy. Is one of my dental technicians, Giuseppe Rampulla, very nice guy, very incredible guy, because developed many things about the approach of the function. In this way, you have the approach to have the point of references, and you can have the movement of the mandible. You can use in a different situation, you see, and you want to see without maneuver, analyze very well the movement of the patient, thanks different records, intraoral scanner, of course, and the face scanner also, and the CT, the TAC, just to have the movement and to have to split together the result of the scan, the TAC, and look at, you can see, thanks to the movement, exactly the approach and the position to the mandible during the function, during the check, during the hit, etc. This is a new challenge for us because it's possible not to have retouch it and to proofs, etc. It's incredible new knowledge and new approach for us. It's just to start in this month, and I try to for some patients, and it's incredible to put on the mouth without touch nothing. Giuseppe Rampula, you can match everything. You have the TAC, and you have the face, and you have the movement, and you ask to the movement to patient to take the differences and the process and the movement free, etc. In this way, you have opportunity to analyze very well on the out of the mouth in the lab, everything on this kind of instrument. You know, it's a Ithaca, it's a TAC combing, it's a fascia scan, and this is, I can obtain exactly the kind of patient. What kind of patient do we have in front of us? Is the diagnosis, of course, and the prosthetic reconstruction also, because we have the opportunity to have these records on the lab directly. And that is the patient, like I made them some years ago with Romeo Pascetta, and that is the result too. But in traditional approach by articulator and some arcus digma, etc. And that is the result. Is not so perfect, but thanks to the new position, you have a new option too. Is it time to give the words to Jose?
Nini, thank you for this first part. Jose lost his connection for the moment, so maybe you can continue with your slides, or if anybody has any questions, they can address here in the time being while we wait for Jose to reconnect. What do you think?
It's better. I can do longevity if you want to.
Yes.
You prefer, or you prefer to finish here?
Oh no, you can continue, of course. So yeah, move on to the other part. Let's go on with longevity, and when Jose reconnects, he can continue from where he
finish.
Left. Yes.
Okay, I finish myself. Okay.
Okay, thank you.
About longevity, I prepare some cases, just not too many, but just to give you if works or not the approach. This approach works. In the posterior single crown, just 6 years. It's not so bad. It's not a wonderful result, but it's still in good position. In the other side, you have a ceramics. In the up, you have a composite. Composite in this kind of mouth was not so nice. It was an overlay. Venerlay was not so nice. It's suffer the food of the patient, the habit of the patient. This is another porcelain fused metal, and the porcelain fused metal was made 14 years after. You can see it's a nice precision and a nice result too in the occlusion and in the lateral side view. And it's porcelain fused metal again because it was very, very popular, 16 years and 20 years. You see, it's quite perfect is the distal of the mouth and the porcelain fused metal again. And this is another case, Alberto Battistelli. You can see one is I made myself an implant and the crown porcelain fused metal after 20 and more years, 25 years. And then you're still in the good position, 25 and 27. It's a good, it's not problem to up and down also. And then you see the written about that. And the single is a posterior, single anterior, very complicated, very difficult. This was my preparation many years ago. I completely disagree. Many mistakes too, but that was the starting point. Thanks to the Alberto, the result was wonderful. After 25 years, you see the recession about the 2.1, and this is natural.
Nini, sorry to interrupt you. We don't see your presentation.
Yeah, because I'm front of. I'm sorry.
No problem.
Probably a little bit
No,
for the. I start again. That is a posterior. The voice was okay, 6 years, and that was the composite. The hurt, no? You hurt me, just not to see.
We hear you and we see you and your presentation.
Okay.
It's all good. Please continue.
Okay. I'm sorry. And that is another case. And the porcelain fused metal again, posterior again. You see, after 14 years, it's a good result too. And 14 years on the occlusal point of view. And then another case is after times, 16 years, 20 years, you see it's a good result, especially if you, in the last teeth on the check of the mouth of the bite. And this is Alberto Battistelli. We see crown porcelain fused metal and crown porcelain fused metal on the implants I made myself. And you can see the good result, modified chamfer approach. And you see the good stability and integration of the aesthetic and the functional. After 27 years, you see very nice result and the good bone around to the implants in the hydroxyapatite implants. Anyway, you see the paper about that. This is anterior. In the anterior, you have single, and the laminate veneer. You see my bed preparation, and the past was for me was not so nice, but I need to improve my knowledge about the preparation. But thanks to the Alberto Battistelli, you can see the result of the central incisor in laminate veneer. After times, you see, after 25 years, you have a resection for my laminate veneer, but you see the precision too. You see very nice precision that. And the recession is still, you have on the natural and the laminate veneer. It's quite natural, still natural too. It's important to follow in the patient after years and years, understand very well. And this is a case I love this case because one of my first cases for bad restoration. I prepare in the very big time, in very big approach, but the provisional cementation and the final restoration. And look at the result is not perfect, but if you see the creeping attachment means my restoration is very integrated on the gingiva. This is a crown and laminate veneer. She asked on one crown, 1.2, but I told you need also laminate veneer too, and that was only free restoration. Two laminate veneer and one crown is quite good at the beginning, and then we need to follow in the patient too, and to see after 12 years It's good, nice. The crown is good, is not so bad. After 14 years, 14 years is a nice result. And look at time passed for the patient, and now is not so nice, the natural tooth. The other one still good. That depends, of course, the dental technician also. After 16, a little bit a problem to 17, sorry, a little bit problem to recession, but it changed a lot and changed probably the abrasion, the wear posterior, you have age, different age. Other cases, 3 crown, 1 laminate veneer. I don't like to do full restoration. It's better to have just to, it's the daughter test to have the smaller approach. You see the result, thanks to the dental technician again, Giuseppe Romeo. You have the new smile, very nice smile, very nice girl. You have at the beginning and the end. It's nice too, just for 3. After 12 years, is not so perfect. 3 years not in the office, 14 years, still good. Not perfect, but I can rebuild after 14, why not? This is another case of 2 crowns. Actually, probably for anomalies, now absolutely no crown, but laminate veneer. But in this time was nice to solve the problem with a new provisional, to prepare, to have the crown around. This is alumina, and the precision was nice, and just cemented different forma, but not so bad for aesthetic result. And I saw the patient casualty during the recall of dental hygienist after 14 years was not so bad, because still good, and the gingiva a little bit less on the 2.2, but no one recall visit. The X-ray means ensure the precision too, and the occlusal point of view. You have a little bit wear on the incisal edge for the central incisor. Depend of the time you need to knowledge and move to following, the patient. And 19 years is still, and the 2.2 is a little bit less perfect, like a 1.2. But if you see the gingiva means, okay, that is not so bad, still good, but depend of the age of the patient, of course. This is another case. It's another case because I started in 1993. And you see my approach and the shoulder now disagree about the thickness about this preparation, but the technology changed. I disagree about the material also in the frontal area. I need to have metal free, of course, equigingiva maybe. This is micro margin, and look at the result just to, and you see in different times too, because I followed the patient very well. And that this is the result in one side and the other side after 25 years. It's a good result too. And look at, you can see the gingiva. No perfect gingiva during the dental hygienist appointment, but it's good. It's still in the same situation and position. And this is a real success. If you compare the beginning and the after and the end, you see, okay, I can repair, I can do any restoration, other restoration. And the quite finished, full arch, as to me, no surgery, no maxillofacial surgery, and very complicated because the 13 millimeters, it's too much. I removed the post and core, and Carlo, my friend Carlo, it's an incredible surgeon and periodontist. You can put my finishing, the gingival level in a perfect situation. I can take the impression just with one cord and look at it just cemented, a little bit to need to mature, and need to mature also the gingiva. You see the endodontist save this teeth, and the idea is to save everything. Of course, now is less aggressive, but that is was not vital, was just to devitalize. 4 years after, very short time, but good result, thanks to the dental technician, Giuseppe Romeo, again, form, it's so important in this case. If you see the texture and the situation of the ceramic after years, it's incredible, really. It's a nice, it's 6 years after, and 10 years after, not more, because I started 10 years ago to do these cases. You can see the recession in the other part of the mouth, but not in my restoration. In the lateral side, and still good also with the crown and in the posterior. I don't need to invade the tissues to have to put my finishing line close to the, very deep to the gingiva. No. In my idea, intraoral scanner stay out, stay equigingival and no invasive, and maintain no damage, and to have a good result after. And I very nice to see the cases like that, because I think it's right approach, is right the direction, is right the technician, because if you see this texture, it's incredible after years. And the gingival, good. And another, as to me, the mouth, full mouth rehabilitation. And then, thanks to the Professor Gandini, upright in one space, close the space, and another one, open the space, because the patient asked to me, I want to full rehabilitation. Come on, full rehabilitation for, yes, yes. But in this case, you need to have exactly what you need, maybe the exactly works and exactly provisional, etc., etc. Ask, and also the material was porcelain fused metal, and the data technician was Romeo Pascetta. Incredible precision, incredible details, and laminate veneer and crown, and the full arch at the beginning. Needs 1, 2 also in the lower jaw, laminate veneer. At the end, has to me not to touch the lower incisor. And then there was the result and the X-ray about this full arch up and down. And this is 18 years after. It's still good, not perfect. If you want to see there, it's not completely perfect, but it's not so bad. If you see the occlusion and the situation, still good. That was the starting point, and that is the final restoration after 18 years. It's a good approach. The last case is one of my favorite cases. I saw the patient yesterday, and no bone, no teeth, money. That is very important. In this case, thanks to my surgeon, Patrizia Oggioni, we made a lot of implants, not so many, but in a good approach. It was complicated because the idea was to have some implants, some teeth, but you have a problem. You have, of course, the wear, erosion, etc. Was not so easy. Not the programmer in that period, but anyway, you see the proof and the ceramics and the approach of cementation to the impression, and then the final restoration. No good, no perfect, because no bone. The gingival was, the patient asked to me, I have not younger, I want to have, 2004 was the time, the starting point, and then 2009, and then you remember, after 8 years, the bonding and fracture of the canine, we repair, the patient pay again, and then is the result too. Okay, after 10 years, 13 years, after 15 years, you see, you have a little bit problem there, but depends if you use a pen in the lateral, use the pen every day, every day take the pen on the lateral. It's very, but if you remember the starting point, you see, and if you see on the occlusion point of view, you see a little bit fracture, chipping there, but still in the good situation. And this is 2004, and this is after 15 years. The patient, 73 years old, don't need so smile like. This is my last pictures. Thank you for kind invitation. Thank you. Now is the time to Jose to explain to you. Thank you.
Thank you, Nini, for your presentation. I will continue in a little bit with the questions for your presentation. For the meanwhile, Jose, I think like he's online now, he's reconnecting. And let's see when he comes in. Jose, you are welcome to share your screen with us when you are ready. We don't hear you and we don't see you, but I know you are connected.
Non è l'ora. Vado a riportare Tommaso. Capito?
Okay. Sorry about that, people. Can you hear me?
Yes.
Is it okay?
Yes.
Okay, I had a problem with connection here, really. I've done 20 of those and that never happened before. I'm so sorry about that, people. So sorry. And so, thank you, Nini, for your everything you said. I think it's great. You know, I love your images. I love your concept, especially. And when we talk about ceramics, we know that it's very important to do nice preparation. Another thing that you said that I think it's mostly important is to have a good partnership with your dental technician, right? Chris, can you see the screen? Can you see the screen?
No, I can see you, but not your screen yet.
Okay, okay. So now I'm done. All right. Is it okay? All right. Good.
Yes.
So when we talk about composites, composites are different because you don't have anybody to share the responsibility with. You know, everything is done by the dentist. And of course, there are many cases that, like this one here, when you see a composite like this is a recent composite done by a colleague of mine, where we want to try to duplicate, to replicate a tooth that is highly polychromatic, like this one here, like tooth number 11 or tooth number 8. But if you want to try to restore that just with one adhesive and one composite, that's the result you're going to have. In order for you to really mimic the other tooth, all the aspects of translucency, of this high opalescent effect that they have here at the incisal edge, those different areas, different shades, different hues of the color of that other tooth, you need a lot more material. You need a lot of them. You need different, actually not just different colors, different hues, different shades of composites. You need especially different opacities of composites. So that's the main thing. So when we talk about direct composites, we know that it's an art that has to be learned over the years. It's a skill that you have to study and practice always. That's a saying from my good friend Ronald Jackson. And we also need a system that replicates the properties of enamel and dentin, and we see them in nature. And also we need to master a technique that allows us the proper use of these materials, okay? So if we think about the tooth as it is in nature, okay, we know that dentin is responsible for the the appearance of the tooth, it's responsible for its opacity, it's responsible for its hue, means the color of the tooth, its fluorescence, and the resistance. And then the enamel doesn't have color. It's a translucent material. It's responsible for the value, a lower value, a higher value of that tooth. It gives an opalescent effect, especially in the incisal third, and is responsible for the shine, for the brilliance of that tooth, okay? So just for us to make sure, fluorescence is a property that the natural tooth has to emit a blue to white light under the action of ultraviolet light or ultraviolet radiation. That makes the teeth wider and brighter in daylight. So that's important. The fluorescence is important not because of going to a nightclub or something like that, but because when you go with your tooth in a daylight, a bright daylight like we have here in Brazil today, if you don't have fluorescence, the teeth will appear dull, will appear darker, okay? And opalescence is a property that some materials have, that when you have a direct light getting to the material, you have a bluish appearance. But if you reflect the light through the material, you have an orange or brown appearance, which happens a lot in tooth at the incisal edge. It's not always, but it's frequent. So bottom line, dentin is the base of the tooth color, and enamel is like a filter through which the color can be seen. So enamel in nature doesn't have color, okay? So when we are talking about composites, I'm going to go very, very fast here, but just for us to have a little bit of concepts of what kind of materials I'm going to show you at the case, a clinical case I'm going to present here. We know that we need composites that are similar to dentin, which means it has to be a high opacity material, has to have a lot of color, has to have an intense chroma, and needs to have a high fluorescence. And the enamel, the composite, it's completely different material. It's a different material from the natural enamel, okay? So we need composites with variable translucencies, more translucent, more opaque, okay? We need an enamel that has that opalescent effect. We need also, even though in nature enamel doesn't have fluorescence, to restore a tooth, we need fluorescence also in the enamel composite. And it needs to be a highly polishable. And although in nature, enamel doesn't have color, to restore a tooth, we need composite as last layer with color. That's, I mean, colors accordingly, for example, with via shade guide, okay? So those enamels we're gonna call the chromatic enamel. And the achromatic enamel are those enamels that are variants of translucency. They're like milky white to very translucent composites, okay? So this is how you can see in a reflected light the dentin composite, the chromatic enamel, and the achromatic enamel. When we have a light shining through the material, you can see the difference between the chromatic and achromatic enamel, all right? But so, as I said before, enamel, the natural enamel and composites are very different. Composite is pretty similar to dentin, but it's very different from enamel. And we know that in a young patient, the enamel is very thick. It's very thick, and it's more opaque, has a higher value, has a lot of luminosity. It's more dense. It reflects a lot of light. And in the older people, the enamel is thinner. It's more translucent. Okay, it's less opaque. Actually, it's very transparent sometimes. It lowers the value. Okay, it lowers the luminosity. It has less reflectivity. All right, but when we're going to restore a tooth, okay, if we have a thin enamel layer of composite, you have the opposite effect that we have in a real life, okay? Thinner enamel in older patients means a more translucent, lower value, like a grayish shade of color. But if we use a thin layer of enamel composite, usually we have a higher luminosity. And the opposite is also true. If you have a thick layer of enamel composite, your restoration is always going to be gray. It's always going to be gray. So this is where most people get it wrong, okay? Because they put a thick layer of enamel composite, and then you look at your teeth, your tooth, you look at your restoration, and you see that it's gray, okay? It has a low value, okay? Like you see here at this tab of composite. Okay, so actually what we need is composites that has properties such as color stability, wear resistance, sculptability, and polishability, all right? And then in our offices, in order for us to do a proper restoration, we need 4 types of materials. An opaque dentin, we could use any of those brands, okay? I know that the 3M product, some places in the world, it's called Supreme Ultra. In some other places, Z350 XT, doesn't matter, it's the same product. Okay, I know there are other products on the market, good products from Colzer, from other, but those are the ones I am familiar with, okay? We also need chromatic enamels, okay? Any of those are good materials. And some of those, like 3M products and Ultradent products like Forma, they have body and enamel. The body shade is something in between enamel and dentin. It's very good for like class 3, class 5 restorations. And then we need the achromatic enamel. I mean, the enamels, composites that don't have the color, that they don't follow the shade of each guy. It's not A1, it's not B1. It's like high value, low value. It's like milky white, something like that. We need some of them that are very translucent or bluish hue, or has a blue hue, like a blue color, to use at the incisal edge of those teeth, okay? And we need some other ones which are milky white, but not too translucent, not too transparent, okay? So those are the 4 categories of composites that we need to do our restorations in everyday practice. We also need some tints and opacifiers. We have the Color Plus from Care, we have the Creative Color from Cosmedent, we have the Empress Color from Ivoclar, which I like very much. It's a set of 8 syringes. It has 7 tints and 1 opaquer, which is very good. And then we have the Final Touch from Vocal, among others. And then let's see some clinical cases, okay? This is an old case where it's typical. It's a typical case where we can think about, as Massironi said before, young kids, we always try to use composites. We don't do ceramics in young kids. This kid at the time was like 13 years old. He had just finished his ortho treatment, but he had some issues regarding his the shape of his teeth. And one of his teeth was longer than the other one, and the orthodontist couldn't manage it to put them at the same level, to put them both at the same, to make the edges even. She couldn't do that, so she said, okay, try to do something. So this is a case where we can just add composite to the surface of the tooth. It's a very young patient. We don't touch the enamel here. Okay, we only do some prophylaxis and that's it. And then we're going to try to replicate all those stains, all those marks, all those details that the other tooth has. It's a challenging, and that's when I remember what Ronald Jackson said at the first slide that I showed you, okay? You need practice. You need to know how your composite looks like once you polymerize it, and after 2 or 3 days, how it is. So you need to be familiar with the material you use, and that takes practice. This yellowish hue that you see here is because on the microscope, the light of the microscope is so intense that if I don't have that filter, I won't be able to manipulate the composite because it's polymerized prematurely. Okay, so you see, I'm using dentins. I'm going to go through the steps at the next case, but this is the result. The first result, you see, this is not good. This first result here is what I meant before. It looks gray. Why? Because I put too much enamel. I put too much enamel shade. Okay, so then I fixed that a little bit, and then I got the proper look that I was aiming for. The product that I used here was 4 Seasons for Ivoclar, which is not on the market anymore, but was a great product. So this is the case before and after, okay? And this is the case of the patient 13 years after, 13 years in function. It's still okay. In those 13 years, I didn't do anything to those teeth, anything, okay? No repolishing, nothing. That's how we did it. This is another case where the patient was complaining because his composite here was always chipping. And the reason because that was happening is because his occlusion. No matter what material you put here, it's always going to be a problem if you don't fix his lateral guidance here, his canine guidance. So you need to do that. So that's what we proposed to him. We proposed to increase a little bit of the height of his canines, both sides, okay, to get a better disocclusion at that part. We wanted to close those diastems between the lateral and the canine, and we also used to, and of course, we were going to do the restoration of that tooth, especially. So we're removing first the old composite, and this is the image that we have on the microscope. You can see exactly where the old composite is that you are removing. You have to be very careful. We don't want to remove more sound tooth structure. And now we're doing our bonding, okay, total latch. And the first thing we're going to do, we're going to start our restoration from the palatal side to the front of the tooth, okay? So we made like a matrix, a silicone matrix from wax up. And now we're going to use an achromatic enamel, an effect enamel, so that we can put that onto the matrix, and we're going to make just a thin layer of composite. After that, we're using here, I'm going back here a little bit, you see, this is a metal matrix that we usually use for posterior teeth. And here we put it inversely. We put it in a vertical position, and then we're going to build the proximal wall of that tooth. We built the palatal wall, we're building the distal wall with a chromatic enamel, I mean the final shade, and then we're doing the mesial, and now we're going to put the center of our restoration. We're going to start with an opaque dentin, we're going to shape the mamelons, we're going to put between the mamelons some opalescent composite, and then we're going to put our chromatic, here we used some tints just to have some effect, a little bit of white from Empress color, and then we're going to use our chromatic enamel, and in the incisal edge, because he has a more translucent area, I'm also going to use an achromatic enamel, okay? So it's a kind of complex restoration. It's a complex restoration. I use the milky white here, just the incisal part of it. And we use that mylar stripe just to drive the material through the contact points. We don't leave it there, okay? We just use that to get a proper contour of the composite around the tooth, all right? And once I polymerize it, we start finishing and polishing our restoration. And of course, we're going to check the occlusion again. And then we're going to do the other teeth, and that's the final result that we have. Okay, of course, the patient had some bleaching before, so this is his before and after. Okay, and of course, if we see like a scheme from what we have here, in this case, we use a lot of materials. We use achromatic enamel in a palatal shell, we use opaque dentin, we use chromatic enamel, we use a tint, blue tint, white tint, opalescent composite, achromatic enamel. Of course, you see here, we don't, this line here is the enamel dentin junction. Okay, enamel dentin junction. We see that the opaque dentin go all the way through the bevel. Okay, I have only at the maximum 0.5 millimeter of chromatic and or achromatic enamel as the last layer. Otherwise, I'm going to have a very grayish, a low value restoration. Of course, this is complex. Sometimes we can make it easier. Okay, we can make it easier. We can do like this. Okay, we can also do the same chromatic enamel that we had, that we're going to have at the last layer, we can have at the bottom layer. So this is like a simplified composite. Chromatic enamel, opaque dentin, and opalescent composite. I think that 75% of all restorations that I make, I do like this. All right? Sometimes you can use, if the tooth doesn't have an opalescent effect, if the tooth doesn't have the opalescent effect, we can use just enamel and dentin. And today, some people think if we couldn't use just one material, okay? And yes, there are some companies that are trying to have a simplified shade composite, like Omnichroma from Tokuyama. They have only one shade, and then they have the simplified shade from Filtech Universal. I've tried some of them. This is a case where I have a class 3, class 4, multiple restorations. Oh, sorry about that. And in this case here, I use just one shade. One shade. That's it. That's everything I used. Okay, and that's, of course, that's not an enamel shade. That's more kind of a body shade, because if it was enamel, all those restorations would look great. Okay, so that's it. So this is another difficult case. You see here, this is a case where the patient has a lot of issues. She has one dark tooth, but she also has some different in levels of her gingiva. Her left side, the gingival level is much higher than in the right side. So we tried to make something, a proposition to her to change that, to do something different. But she said, no, I don't want that. She said, no, that's not what I want. I have one problem. I have one dark tooth. I want you to fix just one tooth. So with just one tooth like that, you can't do just one composite. It's impossible. If you see the tooth that we're going to replicate, which is this one here, tooth number 11 or tooth number 8, you see that it has a lot of areas of low value. You see very grayish areas. You have a crack here. You have some white stains. You have a white stain here. You have some brownish. So in order for us to reproduce that, you need something more than one product. You need several products, okay? So the first thing we do, we're gonna do a preparation of that tooth, as if we were doing a preparation for a ceramic veneer. Same thing. We can use all the technique that Domenico just showed us with his burrs, with the sonic points, which are great. Okay, so we're going to have to prepare so that we can have enough room for the several layers that I'm going to put over that tooth, so that I can have a natural look, so that I can mimic the other tooth of the patient. Okay, so this is where the precision of the microscope is essential when doing those preparations precisely. You see that many of that are inspired on Nini's slides and Nini's videos from the past. You know, I always look up to that. So this is the final preparation, okay? Of course, we have to prepare a lot. Still, we have a lot of enamel here, but now we're going to do our restoration. So we're going to bond, we're going to do total etch, we're going to put our adhesive, and we're going to use some opaquer, some liquid opaquer. This opaquer, this one I use from Ivoclar, okay, from its Empress color, opaque. It's one shade, about A2, A3, somewhere around that. But you're going to see that it's not going to be an even layer. It's like sprinkled around the tooth. You're going to have all these sprinkled. You see? It has to be like that. And then I'm going to use a darker shade of dentin on the cervical area and a lighter one on the medium and incisal thirds. Now I'm going to make my mesial surface, my mesial surface, my mesial part, and now the distal. I always use the Smiler stripe, not to leave it there, but just to support the composite that I'm putting. And then when the composite is in place, I tack it down, you know, I pull it front and back, and then I pull it to the palatal side so that I can have a proper contour. You see that? Now I'm using the chromatic enamel, the final layer, a darker one at the incisal. I'm using some tints, some blue tints, some white tints, so that I can mimic those stains that the other tooth has. I'm leaving some space, and I'm doing a crack. That's how I do. I use a miler, you know, to make a cut onto the composite. Then I put some white tint, I polymerize it, and then now I'm putting an incisal, a more achromatic enamel over the medium final third, medium incisal third of the tooth. And that's the restoration at the end of it. When we just finish it, we don't know if that's good or not, because the other teeth are very dehydrated. So we always tell the patient, wait 2 days, 2 to 3 days, and then you come back. Then we're going to see if we need to do some touch-ups, if we need to do some repair, or if we don't, which was this case, we just polish it a little bit more. Of course, that when we finish this, then the patient thought, you know, I don't like, you know, the gingiva at one side, you know, everything I told her at first, you know. So then, but I didn't want to do like a huge gingivectomy, because if I was going to do the gingivectomy to make those teeth even, I would have to do some osteotomy, and then I was going to expose some dentin from the root of the patient, and I don't want to do that. So I did a very easy, a very simple gingivectomy just with a laser, just a little bit. It's not perfect. It's not going to be at the same level at the other side, but it's going to get a little better. And the best thing, I'm not going to expose any root dentin. I don't want to expose that. I just want enamel. She's a young patient. She's only 32 years old, okay? So that's what I did. This is a diode laser, okay? And that's the final procedure, okay? So that's the hardest it gets. Some people might think, you know, you see, there are a lot of layers there, a lot of layers. Could it be simple? Yes, we can try to use those universal, not in a case like this that I showed you, but in a more simple case, you know, you can add a little bit of opalescent composite. So a case like this, where a patient lost an old restoration that she has a nindle in this tooth. So actually here, if you're thinking about which material is best, of course, a ceramic restoration would be, and not a veneer, a crown, a full crown would be much better. That's the right indication. But it was a Saturday, the patient was from out of town. I wouldn't have time to do that, so I did an easy composite restoration. It's a transitional, okay? It's a provisional composite restoration. So I used only 3 masses of composites, okay? I used Filtech Universal and 2 Filtech Universal. One that they have, which is the pink opaque to mask dark substrates. And I used 1 universal, the color was like, I think it was A1. And then I used some opalescent from Z350, okay, from V350. So just to have a better opalescent effect at the incisal edge. You see, that's I made this silicone matrix from her previous restoration. Okay, that wasn't a WhatsApp. I just put the restoration in place and built that matrix. So that's not a shell, a thin shell. That's a thick shell. Okay, that's a thick shell. That's different. Okay, because that composite is more opaque. It's not like dentin, but it's more like a body shade. Okay, so same thing. Okay, I'm building the proximal walls of that tooth. I'm going to go a little bit further here. Okay, I did the mesial. I did the distal, I'm doing the mesial now, you see? And now I'm putting, I don't have dentin here, okay? This is the opaque, pink opaque to mask dark substrates. It's a special opaque composite from Filtech Universal. So I used that, And then I put a little bit, I put a little bit too much, and then I remove a little bit. I put some more universal composites, and then I put a little bit of that opalescent effect composite in the sisal edge, as you can see there. And then a final layer of A1. That's it. After doing that, very carefully, I start shaping with some discs. I really like the Softlex XT from 3M, okay? And then I use some rubber points. I use some finer discs so that I can get a better shape. This is a magic mix from BioClear. You can use some other pastes, some other systems. This is the twist from 3M. And then this is the final restoration. This is the final result, okay? So this is where we started. And this is, of course, here is a case that we were pushing those composites too much, okay? We're pushing it too much. Here, the ideal would be to make a ceramic crown. But due to the circumstances, okay, we had to do something to the patient. This is a case that we did, you know, I'm not going to go through this. It's inferior. We use the system that is called BioClear, where it's very good to close diastemas and black spaces, okay? You can see here. I use just one shade again, just one shade of that, okay? So this is the system, all right? And the final result is this one here, just one shade, just one shade. And it's interesting because this patient here, it's been a patient of mine for several years. The first time I saw him was in 1998, where I closed those diastemas. I put those two brackets here just because his frontal diastema between those two centrals were too wide. So I put some brackets, some rubber tape just to close them a little bit, just a little bit, so that I could get a better proportion. And then I restored the laterals. And then I restored the centrals. At the time, I used Herculite, and as the last layer, I used Renamel from Cosmodet. The patient disappeared, and he came back after 11 years. And restorations were all there. I just repolished them, and then patient kept coming. That was a few years later, and then here, after 20 years, okay? Not every time he came to the office, I had to do the repolishing and everything again. Over this period of 20 years, I only touched those composites 4 times. The first time I made them, 2 in between, and this one here, okay? So you don't have to be repolishing the composite every time the patient comes to you. Every year, no. The less you touch it, the longer it will last. Okay, so, but here it's, you know, you have to be very careful because it's almost at the end of its life. Okay, so that's after repolishing. Okay, this is 21 years, and this is 22 years. But now that I fixed his lower teeth, before he didn't have those lower teeth fixed. I just did that last year. After 22 years, he chipped a little bit here. Can you see? He chipped it here. You know why? Because now he can do this. He wasn't able to do that before. Now he can do that. I told him, don't do it because of those restorations. But is that a failure now? No, I can repair that. It's not so difficult. You know, I need to sandblast it, you know, use a proper, you see, there's a lot of enamel here yet. I put just a little bit of composite. Of course, it's not the same composite because I don't have that composite anymore. I use the one from Massironi, which is achromatic enamel. I finish it. Now I repolished everything. And we are aiming to go to 25 years. But this is 22 years, okay? So when we talk about longevity of composites, because many people think that composites don't last too much. They do. You just have to be careful with them, okay? You have to do a proper diagnosis, when to use it, and how to use it, and when to replace it. That guy that I just showed you, probably if he was going to another dentist, somebody could have told him, okay, let's change all those composites when after 15 years is good enough, let's do some ceramics. So it would last 15 years, but it's lasting still 22 years, okay? You have to select the right composites. It's not the color, it's the opacity. It's the resistant, it's the polishability. The more resistant composites have less polishability. The composite that has the best polishability that I think is Renamel from Cosmedent, and also this one here, the Stellite from Tokuyama. Those two, they're very good as long-lasting polishing, but they're not strong. You have to use them over a strong composite. It's a complex restorative technique mostly, so you have to practice. All right, you're not born knowing how to do composites. You have to practice it. You have to do a proper isolation. It doesn't have to be rubber dam all the time. If you have super gingival, if you can control the moisture in your field, but usually I love to do with rubber dam isolation. Use your adhesives correctly. Read the paper that comes with adhesives, with the steps that you should follow. Don't do that out of your head, okay? Adhesives are different from different brands. You have to read the how do you say? You have to read the paper that comes with it, the directions. You have to read the directions. Many dentists don't do that. You have to do a proper light curing. You have to have a good light source and use it thoroughly, very strongly. You need to have a proper finishing and polishing, okay? Using your discs, using your rubber points, using your felt and polishing pastes. A polishing paste that I really like for composites is also from Cosmedent, is the Enamelize. It's a very good one, okay? So you make a sequence, your own sequence. There are several ones, there are several materials available, but you try to have the best shine out of your restorations, okay? And then probably it will last longer if you do that. Check the occlusion always, in all the movements, okay? And of course, you try to be as accurate as you can. Be precise. You need some type of magnification. You need some type of magnification, okay? Either a loop or a microscope, all right? But you need some type of magnification in order for you to have a more precise restoration, okay? So be careful with the instruments and tools you choose. Don't use everything. Some people like to use loops and microscope all at the same time. But if you do that, you keep moving around. Like I'm doing here, with a microscope. Then you don't see properly. Then you try to look at the sides. You have to use it in a regular basis so that you are using. You make that a routine in your life. Okay? You can't be changing all the time. This is not how you use a microscope. And sometimes you keep changing. Of course, we were fooling around, but that happened. That really happened. I forgot to take off the loop with the microscope. Okay. So, an important thing, okay, the use of a microscope won't make you a better dentist than your friend, your neighbor, okay, or your colleague, but it certainly will make you a better dentist than you were before using magnification, okay? Because of course, you do better when you see better, okay? Muito obrigado, grazie, thank you very much.
Thank you, Zé. Obrigada. Nini, thank you so much. Both fantastic presentations. I couldn't be happier to join this learning time with both of you. And I hope our friends at home enjoy, and I've got already some messages of thank you so much from